Okay, so hypokalemia is where we're going to pick up now. So that is where our potassium level is below 3.5 in our serum level. Alright, so causes for hypokalemia can be from GI losses of potassium, things like diarrhea, intestinal drainage tubes or fistula, laxative abuse, vomiting. Alright, we can have too much potassium losses through our kidneys from the use of diuretics, excessive aldosterone production, low plasma magnesium concentrations, diet problems, which is rare in the United States, things that will cause a shift from our extracellular to our intracellular spaces like respiratory alkalosis, or problems with a complication of pernicious anemia, which is a vitamin B12 issue. Right, when we look at hypokalemia, right, it's going to cause issues with the signals that we have between our muscles and our nerves. Right, potassium is needed for that membrane potential to occur, if you remember back from anatomy and physiology, in order for a muscle contraction to be done properly. Right, so it changes the excitability of our cardiac, neuromuscular, and GI functions. GI symptoms we see as a result are nausea, vomiting. They can also have constipation or an ileus, where they have no movement in their intestinal tract, and the contents then get stuck or lodged, and it can be a surgical emergency. Neuromuscular, they see things like muscle weakness, cramping, and if it's severe, it can lead to paralysis of their muscles. Cardiac changes are our biggest concern, right? So we'll see EKG changes. That's changes in the electrical conductivity of the heart. It can cause things like postural hypertension. That's where they stand up and their blood pressure falls for no real good reason. And they can have an increased risk of digitalis toxicity. So if they're on digoxin for their heart, it can be a problem. Right, so this is a EKG waveform. Right, so we see our P wave, QRS, and T, and what happens in hypokalemia is we get this extra U wave. Alright, so that means that we have improper electrical activity of the heart. Alright, this little image is just to help you, if you're a visual person, to think of our little patient here who needs help. She feels she's having a change in her heart rate or in her heart activity. Sometimes patients will feel like they have a flutter or an extra heartbeat. Right. It can also cause PVCs, which are premature ventricular contraction, where we get these big extended QRS waveforms on their EKG. Alright, treatment of hypokalemia, we have to treat the clinical manifestations. If we have cardiac changes, that's our biggest concern, right? And we have to bring or regulate their serum levels. To determine the cause, do they need better nutrition or dietary intake, stop GI losses, so give them antiemetics, antidiarrheal medications. We can supplement their diuretic or supplement them with potassium if it's from diuretic use. Right, they may need IV or PO supplements. Right, if they have a magnesium deficiency, we may need to also correct that because magnesium and potassium tend to correlate to each other. Right. Suction's an acronym that can help us remember, one, that you can get hypovolemia from too much NG suction. So if you're caring for patients who have an NG tube, we have to watch that we don't suck up too much of their stomach contents, because then we'll suck up their potassium sources as well. And it also helps you to remember some of the signs and symptoms that go with it. So S, skeletal muscle weakness. U is that we see a U wave. If you ever see a U wave on an EKG, it's because of hypokalemia. People don't really get it for any other reason. C, it can cause constipation or an ileus. T is for toxicity, specifically from digoxin. I is the irregular heart or irregular pulse that you see on the EKG. O is for orthostatic hypertension, and N is for numbness, because remember it can cause problems with our muscles. Right, hyperkalemia is the opposite. Our potassium level is going to be 5.0 or above. It's usually because they've had excessive potassium intake, or that we've had a shift from potassium in the cells to the extracellular space. So essentially it's not where it should be anymore. We're causing it to leak out of our cells and get into our fluid for some reason. This usually occurs when we have a massive cell trauma, so something that damages a lot of cells in one fell swoop, right? Because all those damaged cells break and they release their potassium out of them. So things like burns, crush injuries, and our extensive surgery can do this. Acidosis, where our pH level is too low, can cause potassium to shift out of cells and into extracellular spaces. If they have an insulin deficiency, right, because then the insulin's not going to push potassium in the cells, it will be, if it's deficient, it's going to leave it out. If there's cellular hypoxia, right, because that means the lack of oxygen is going to cause the cell membrane to not be as efficient, so potassium will leak out. Also, if we can't get rid of it like we're supposed to with our kidneys, then it's going to build up in our volume again. Right, so oliguria would be where we don't have enough urine output. Right, most people make above 30 milliliters of urine an hour. Right, if someone's below that, that means that they're not making enough urine and they could not be getting enough potassium out of their kidney, and then it would stay in the circulation. Right, if they have decreased secretion of aldosterone, or if they're taking potassium-sparing diuretics, it can also build up as well. Hyperkalemia is going to alter that membrane potential and cause excitability of our cardiac, neuromuscular, and GI functions. Right, so GI, they're going to see problems like nausea, vomiting, cramping, and diarrhea. So opposite, it's not constipation, we're going to see more of the other problems with diarrhea and cramps. Right, they're going to have neuromuscular changes like weakness, dizziness, paresthesias means they feel like numbness and tingling sensations. They can also get paralysis if it gets severe. Cardiac, we're going to see EKG changes, and we can have some severe complications because of that. We can get ventricular fibrillation, where instead of the ventricles beating, they're going to just quiver and shake, and they never express the blood out of the heart to circulation. On the EKG, we see tall peak T waves, and I have some images of these in a minute, in a wide QRS complex. And then if they're on digoxin, it's not going to work. This little guy is just to give you an image if you're somebody who likes pictures to help remember things. Down here is a drawing where we can see our QRS is wider than usual, and we have this T wave after that's now peaked. Alright, it's above the level of the P wave, it's taller, and it's more pointed than usual. On a real EKG, alright, this is a tracing that we can see. If we look down here in lead 3, alright, these are our QRS's, and then look at how tall that T wave is after. Alright, it's almost as tall as our QRS complex. It should be much lower. Alright, to diagnose hyperkalemia, alright, they're going to do a history and they're going to draw a serum level. Alright, determine the cause. We want to eliminate any intake of potassium, so we're going to take it out of the diet as much as possible. Our main goal is to get rid of that potassium before it causes a heart attack through ventricular fibrillation. Right, so dialysis is our fastest way to do that. We may need to bring it down quickly by putting the patient on dialysis. We can also give diuretics to help the kidneys to get rid of potassium. Kayexalate is a medication that pulls potassium into the GI tract, right, through the intestinal wall, and it helps to get rid of potassium through diarrhea. Right, so that would be another medication. Diuretics and Kayexalate take the most time. If they see somebody has a high potassium level and they're having EKG changes, they're going to opt for the quickest route, which would be dialysis. Other methods they can use, they can give insulin. Right, they'll give short-acting, rapid insulin to shift potassium into the cell and out of the extracellular space. They can also give calcium gluconate. This increases the cardiac threshold, right, for the electrical activity, which can spare some of the complications for the cardiac muscle. Alterations in calcium balance. Alright, so our normal calcium level is either 8.5 to 10.5. Alright, we have calcium mostly in your bone. You hold on to 99% of your calcium in your bone. Alright, and then mostly after that, that 1% that's left gets split between your intracellular and your extracellular space. So about 0.7% goes in the cell and about 3% or 0.3% goes to the extracellular space. We need calcium for our bones and our teeth, but we also use the serum calcium levels for blood clotting, hormones, alright, and function of our cell receptors, as well as our heart and our contractility of it. Right? those things only get used by the free or ionized form of calcium. So there's 1% that's not in the bone. All right, that's what we use for our neuromuscular and cardiac activity. Okay. We get calcium through our GI tract. So parathyroid hormone promotes the release of it from the bone if we need it. All right, vitamin D helps us to absorb it, so that's why you usually will see if you need a calcium supplement, you should also take a vitamin D supplement. This is also why we add vitamin D to milk, right, to help us increase absorption of calcium from milk. Calcitonin is a hormone that helps us remove calcium if we need to from our body. It gets excreted by the kidneys, right, and it has a reciprocal relationship with our phosphate levels. So if we see one affected, then it impacts the other. Hypocalcemia is where we have a decreased level in our blood. All right, so it's less than 8.5. It can be caused by renal failure because this decreases our vitamin D and increases our phosphate level, so that drives potassium or calcium out. We can also see it caused by a decreased or absent parathyroid hormone. It can be a complication of pancreatitis, and if we have elevated phosphate levels. What patients feel, they can have hyperreflexia, which means they often have twitching muscles. Right? They can get different twitches that are specific only to hypocalcemia. Chekhov's sign or Trousseau's, and I have an image of these coming up. Right? They will also experience numbness and tingling around the mouth. They may have laryngeal stridor when they're talking or breathing. They'll get tired very easily, right? The easy fatigability. And on their EKG, we can see ventricular tachycardia, so a high heart rate in the ventricles, right? And a long, elongated ST segment. All right, so Chekhov's sign, I think CH, cheek, right? This is where if we tap right beside their earlobe on the side of their jaw, right, it will elicit a twitch, and the side of their mouth will twitch towards the side you're tapping. Right? They can also get Trousseau's. Right? In Trousseau's, what happens is if we put a blood pressure cuff on and they have a low potassium or low calcium level, right, it's going to cause a muscle twitch in here. So then their arm curls in, right, and their fingers curl up like this. Right? This is another image of it here. It's a carpodial spasm that can happen. All right. So we would diagnose them by getting a serum level, looking at their history and their risk factors. All right, we need to figure out what the underlying problem is and treat that. We can give IV supplements of calcium if they have any tetany or twitching problems. All right, they can also maintain with a PO supplement if it's going to be a chronic issue. Hypercalcemia is often a problem with hyperparathyroidism because it's going to signal too much release of calcium from our bone. It can happen with malignancies or tumors in that area as well. If someone gets too much vitamin D, right, that means they're going to prompt too much absorption through their intestinal tract. Right? If we have prolonged immobilization, this can also cause it because we are going to have release of calcium from the bone breaking down from them being immobilized and not using them. And acidosis can have a problem because it will increase our serums, our ionized serum calcium levels, those parts of calcium that are not in the bone but in our circulation. What we feel then is that it's the opposite of hypercalcemia. So we see depressed reflexes, people are very lethargic, they're going to have changes in their level of consciousness, so it'll be hard for them to stay awake, have conversation, talk to you. They will be stuporous, they'll be stumbling, slurring their speech often. Right, they will feel, they will have anorexia, nausea, and vomiting. On their EKG, we see things like a short ST segment, a short QT, and a decreased contractility of the heart. All right, their serum level will be above 10.5. Our main goal is to rehydrate them and increase urinary excretion to push it out through the kidneys. All right, they want to promote excretion. They can use loop diuretic medications. They will give isotonic solutions to decrease the likelihood of too much calcium building up in the kidneys and causing a stone. Magnesium is our second most abundant intracellular ion. Right, we need it for ATP, or our Krebs cycle of our cells. Right, it also makes our cell lines function. We get it in our diet. It's excreted by our kidneys. Right, causes for